Welcome to Rhythm Interventions Unplugged, your monthly deep dive into the world of electrophysiology. Join us as we explore the latest research, share clinical insights, and provide practical tips to keep you at the forefront of your field. Now here's your host, the Director of Cardiac Electrophysiology at St. Bernard's Medical Center, Dr. Devi Nair.
Welcome, everyone. I'm Dr. Devi Nair, Chief of Electrophysiology at St. Bernard's Healthcare in Jonesboro, Arkansas. I will be your host today for this podcast. Today, we're diving into the really timely and important topic, pacemaker leads in the setting of tricuspid valve interventions. I'm joined by two very distinguished colleagues, Dr. Larry Epstein, System Director of Electrophysiology for Northwell Health in New York, and Dr. Rob Schaller, Associate Professor of Clinical Medicine at the University of Pennsylvania. Thank you both for being here. Tricuspid valve disease is increasingly recognized, and with the expansion of transcatheter repair and replacement options, we're seeing more patients with devices in place. Robert, could you briefly outline why pacemaker or ICD leads can be problematic for the tricuspid valve and the structural specialists?
Sure. Well, there's a couple of issues. One, leads can cause tricuspid regurgitation. We're not exactly sure if they're the sole contributor in some patients or they just start the process, but they definitely can increase the degree of TR. So they could be the cause of severe TR and needing a percutaneous repair. But once that diagnosis is established, you have to figure out what to do during the implantation of the TTVR, because if a stented valve is placed in that annulus with a lead in place, it'll jail or entrap that lead against the annulus, and then that lead will no longer be percutaneously extractable, at least not in traditional ways, and that causes a whole host of problems. So a decision really needs to be made before that TTVR goes in, whether I'm going to accept those consequences in the future or whether I'm going to try to take that lead out first and using a different type of pacing solution for the foreseeable future.
Yeah, and I think if you look at it, studies have shown about 30% of people that have valves across their tricuspid valve ultimately develop some degree of TR, some severe. And the converse, or the related side of that, is if you look at people with severe TR, about a third of those patients have leads. So the two go together. And I think the key takeaway that Rob and I have been trying to put out there is that an electrophysiologist with experience in lead management has to be part of the structural heart team taking care of these patients.
Larry, it's a great point, both of you. So let me ask you a question, Larry. When you're evaluating a patient with both the need for pacing and significant TR. So now we're kind of starting ahead. We don't have leads in place already, but we have a patient that has both TR and needs pacing. What are the biggest challenges that come to mind to you? And what should our audience keep in mind?
So again, it's the team approach, right? When we see patients come to medical care via many different specialties, and that's part of the problems. They may come to the electrophysiologist because they need pacing. They may come to a cardiac surgeon or a structuralist because they have tricuspid regurgitation. And our approach has been we all work together. So even in the same day, I'll be seeing somebody and I'll walk them down the hall to see my structural person or my surgeon. And then we plan ahead what to do. You know, how do you think you might want to treat this TR? Is this somebody that's going to go for a surgical repair? So if they're going to go for a surgical repair, it makes sense for the surgeon to put on epicardial leads at the same time. If they're not going to go for a surgical repair and it's going to be a transcatheter base, then we think about what are the ways we can pace this patient that is not going to interfere. And as Rob said, that the lead's not going to be gel. So either pacing via an LV-only system in the coronary sinus or with a leadless pacemaker. And that decision often gets made on what their LV function is. But clearly, the team approach is important. And I'm probably going to say this about 12 times during this meeting, that getting everybody together and kind of thinking about it ahead of time is really crucial for the best patient outcomes.
Rob, let me kind of ask you two sides of the question. So And please, both of you jump into this. I think one is very important from an EP standpoint, and when we collaborate, these are discussions that happen in the room. Like, how do you decide whether to extract the lead, or what is that right patient that you will tell the team, listen, this is what I think needs to be done, and are there strategies that you prefer from a pacing standpoint, such as his bundle pacing or CS pacing or leadless systems? Can you both elaborate a little bit both on these two aspects?
It's the $1,000,000 question: who to extract and who to abandon. And clearly, it needs to be thought about on a patient-to-patient basis. And I find it easy to think about extremes. If a ventricular lead is 2 years old, 3 years old, even 6 or 7 years old, it'll be a real shame to entrap that lead because they can have some serious problems moving forward. However, if a patient has 3 leads across that tricuspid valve, they're 30 years old, and the patient is 98 years old, clearly the risk-benefit profile leans towards too much risk for an extraction procedure like that. But that's rare. So I think the default should be, let's seriously consider taking these leads out, knowing that the complication rate is so low at high volume centers. And of course, you don't even have to worry about damage to the tricuspid valve during these procedures, which is a significant portion of the low complication rate during these procedures. And that way, we don't have to worry about anything moving forward. Other things to consider is that patient pacemaker dependent? Because not only can you not remove an infected lead later on if it's trapped, at least not with traditional ways, but what if that lead breaks because it's been jailed in the annulus? We know that the rate of leads breaking, probably because of insulation issues, is probably above 10%, but we don't even know. It might be higher. So if that patient's dependent on a single lead, you should seriously consider either removing the lead or adding some redundancy. And we have so many ways now of pacing patients. We have ventricular leadless pacemakers. We have dual chamber leadless pacemakers. We know all types of different ways to put both pacemaker leads and defibrillator leads into the coronary sinus system. In fact, we just published a nice paper in your journal about what the options are. So as long as you discuss what the patient's needs are with all of the people on that heart team, then you can come up with a great plan that can provide that patient with all of their pacing needs and mitigate the risk long term.
Yeah, I completely agree with Rob. And one of the big problems we're facing is this misperception about what the risks of extraction are, coupled with the lack of access to high volume extractors at some places and people just not wanting to refer. So I've been going to a lot of the structural heart meetings recently. And unfortunately, there are folks out there that are jailing leads left and right all over the place. And not only for the reasons that Rob brought up about what the risk of jailing the lead is, we just looked at 25 patients that we extracted specifically for TR in planning for them to get a transcutaneous valve. In 7 of those patients, the TR got better enough that they didn't need the valve intervention. And, people have this idea that the risk of lead extraction is so high. If you look at the 30-day mortality of the TTVR procedure, it's 3.5%. The risk of lead extraction is an order of magnitude lower than that, or even more so. So this misperception of the risk of extraction, the lack of availability, or the lack of a willingness to refer the patient to a high volume center is resulting in a significant portion of patients getting procedures that they may never have needed if you take the lead out. And, in our experience, it's not just the 1 or 2 year old leads, which in my mind, I'm going to put it right out there, is malpractice to jail a 1 or 2 year old lead. One of our patients had a 13-year-old defibrillator lead that I took out, and the TR got better. To my surprise, I never thought it would, but you never know. And I think that's a really big issue.
Larry, while you're on that topic, I know you mentioned a little bit on your data, and Rob, you mentioned about data that you just published. Can you both maybe share a little bit more data or what you have for the recent data and registry experiences, like telling us outcomes on, patients who undergo tricuspid interventions with leads in place. Maybe a little bit about procedural feasibility. How does it affect the valve durability? Safety of extraction data, etc. Like, how do you time it?
Yeah, I mean, it's interesting. So we're getting data, and unfortunately, I'm really scared what the data is going to show with all these leads that are being jailed. But the early data suggests it's a real problem. Upwards of 10 to 20% lead failure rate in these patients. The folks from Emory just published a study that showed there were 3 lead-related issues with jail-in resulting in 2 deaths. And there's something called the TriPlace registry, which is unrelated to industry, where they're gathering data on it. I'm going to look down because I kind of wrote down the results. So at 6 months only, there was a 6% lead failure rate with a 25% increase in threshold, leads that are probably going to fail. But maybe this is something that will get the structuralist attention. There was also a higher incidence of residual TR. It was 9.3% versus 3.8%. And a higher need for valve reintervention if you jail a lead, which makes sense. If you've got something along the annulus that you can't really conform around, it's going to be a problem. So it's a combination of lead failure, worst outcomes for the procedure with TR, and the need for reintervention. All the more reason that you need to include an EP in this. And it's not just any electrophysiologist. Rob and I and you have seen our EP colleagues who abandon leads left and right, and people show up with 7 leads. It has to be somebody that is well-versed in lead management.
I think your audience should understand that in high volume centers, the risk of lead extraction has been whittled down to less than 1%. And we all do things a little bit differently. But if you understand the basic tenets of lead extraction and you leverage certain new technologies such as ICE, it's just become so rare to have a problem. And I think the glaring problem in the future is going to be infection. And that's going to get all of the headlines because we're going to have to try to take some of these leads out, which are entrapped because they're not surgical candidates by definition. And we have some experience doing that with leads that have been jailed by venous stents, which is also a big no-no. And those procedures are so challenging. They are no longer predictable. You can no longer use your traditional tools in traditional ways. And you have to think about all sorts of different ways to get these leads out. And usually you can't get them all out. But I think the elephant in the room, the unspoken problem, is going to be what Larry was just talking about. It's going to be leads failing in patients who are dependent. And they will those cases probably won't get the headlines that the infection cases will be. So it's so important for these registries and trials to keep track of what happens to these leads over time so we know what the incidence is. And I've been a little bit disappointed that many of the structural people, industry alike, don't even understand what the probable mechanisms of the lead failure is. It's not simply the lead probably coming back a little bit because it's been entrapped. These leads are 15 years old. They're not coming back. It's probably due to structural damage to the lead because of the insulation. So we have to learn so much more about what the natural history of these leads are, but we shouldn't allow patients to be at risk while we're learning that.
And Larry, let me just ask you a question for our EP colleagues. Are there tips and tricks that you recommend to our electrophysiologists as they implant new leads that can potentially maybe prevent tricuspid lead issues? What are the little do's and don'ts for our EP colleagues?
That's a great question. And I've always thought that being an extractor has made me a much better implanter, right? So I've seen all the reasons I've had to take leads out. So I very much try and avoid that, whether it's how, that I use cephalic cut downs and not medial subclavian punctures and all of that stuff. But when it comes to the tricuspid valve, I think we need to be more careful. And, I always try and prolapse the lead across the valve as opposed to going straight across with the tip of the lead. You see cases where the leaflet may be perforated or the lead gets entangled in the subvalvular apparatus, which is going to cause issues. I think if you're doing physiologic pacing, there's data out there now that shows that the distance from the base is important to the degree of TR. So you want to go further away from the base when you put the lead in. Also, you want to make sure you put enough slack. I've seen plenty of cases with 3830 leads where, there's no slack. So the lead is tenting the septal leaflet right against the septum and causing TR. And with leadless pacemakers, you want to make sure you're further enough away from the annulus so that the end of the device isn't interfering with the cord A or the valve itself. So there are things we can do to try and prevent it. And I think often people haven't thought about that, but I think more and more it is a growing concern. So that's a great question.
I completely agree with what Larry said. And just to add to that, we've looked at whether prolapsing affects the amount of TR moving forward, and we didn't find any correlation there. But I think as an extractor who uses intracardiac echo during extraction procedures, it's very common to see leads undermining cords on leads that you're taking out. And that can be a serious risk factor for injuring the lead during removal. So I think the default should always be prolapsing, even if it's only to decrease the chances of TR during extraction. And the one other point I would add is that as an implanter, look at the patient's tricuspid valve. If they have severe TR already, then maybe say, well, we're in the TTVR era now. This patient might benefit from that in the future. And then don't put a lead across their valve. Utilize either leads in a CS. We're very good at using 1 or 2 leads in the CS. Or maybe that's the time to utilize leadless pacing. And won't it be great when the leadless pacemaker offers conduction system pacing, which of course you've been working on. So maybe try to see down the road a little bit so you don't have to make that decision about entrapping leads later on.
Those were all great points. And for our listeners, many of whom are, practicing EPs and structural heart specialists, what are your top take-home messages when managing these complex patients? And more as a summary, can you talk about I know, Larry, I'm going to give you one more opportunity to talk about collaboration, but I'll let you kind of start.
Sure. That's the key. It's the heart team approach, and when we think about what are all the things, the interaction between EP and valvular heart disease, one is considering functional valvular heart disease. We didn't even talk about that today, that there are many patients with atrial fibrillation with severe MR or TR, and you treat their AFib aggressively now with ablation, and it gets better. There's patients that have left bundle branch block, and you resynchronize them, and their MR gets better. So having EP involved with heart valve patients, along with the structuralists, the heart failure doctors, the surgeons, is really crucial. Having an EP that is well-versed in lead management, because not all EPs view lead management the same way, I think is crucial. And then for me, the takeaway is, it's individualized, as Rob said. Lead extraction can improve TR, so you don't need the intervention, and jailing leads is bad. So I think that would be my takeaway message.
Yeah, I would just add some nuance to what Larry said, which is, one, the risk of a major complication during a lead extraction procedure at centers like ours is less than 1%. The risk of a death is less than maybe 0.25% in high volume centers or big registries. And it's hard to understand the implications of doing something until you see the repercussions of that. And it's very easy to jail a lead and see that patient do okay or lose track of that patient and not worry about it. But when that patient does come back with an infection, it is an absolute disaster. And you don't want to have to live through that in order to appreciate it. It's going to be our problem, and we're going to try to fix it. But we really want to limit the amount of times that we are in that scenario, because it's going to be very, very challenging. And there's so many different ways for these leads to fail. It's not just leads breaking or insulation failing and patients no longer capturing. They also can sense all this noise on their leads and inhibit pacing. So this is a nuanced type of problem that can affect patients in many ways, and that's why Larry has written so much about this heart team approach. I think the default should be patient safety rather than just moving quickly to utilize this exciting technology that we're all actually quite excited about too. We just want to use it in safe ways.
Well, this has been a really insightful discussion. Thank you, Dr. Schaller and Dr. Epstein, for sharing your expertise. And to me, the key takeaway is thoughtful planning before, after, when you implant leads, when you have a tricuspid valve issue, deciding whether it's a lead-related issue or not, deciding if the tricuspid valve even needs an intervention or is it just a lead-related issue, and then having a team collaboration that makes it all happen. And I think we can't forget that new technologies are opening so many more exciting possibilities that I think the onus is on us to make sure that we do right by our patients. And to our listeners, thank you for spending this time with us. I'm Dr. Devi Nair, and it's been my pleasure to serve as your host. I hope you found today's conversation valuable. This is just the beginning of many more discussions to come at the intersection of electrophysiology and structural heart disease. We look forward to welcoming you back for our future podcasts. Until then, stay curious and stay engaged. Thank you.
That's all for this episode of Rhythm Interventions Unplugged. Never miss a beat. Make sure you subscribe to the podcast and please share your thoughts with a review. We'll be back next month with another episode. Until then, keep the rhythm going.